Hello, I'm Dr. Monica Verduzco Gutierrez. I am from the Long School of Medicine at the University of Texas Health Science Center at San Antonio. Very gracious and honored to be able to talk to you today about post-COVID conditions and long COVID, how you would start with the evaluation and treatment of these conditions, as well as give you a perspective from being a specialist in physical medicine and rehabilitation. Today, the objectives that we will be talking about include defining what long COVID is, or PASC, discussing the pathophysiology. We'll be talking about adverse impacts of COVID-19 on patients, even talking some about related to social determinants of health and healthcare disparities. We'll look at the current literature on what's there, the impacts in different systems for patients who have long COVID, and how you could start treating these conditions using a multidisciplinary, patient-centered approach. A little bit about my background. I am a specialist in physical medicine and rehabilitation, as well as in brain injury medicine. In doing this, it made it very easy to take care of patients who were suffering with post-COVID conditions, as I've previously taken care of patients with severe critical illness who needed recovery, also with patients with more even concussions and had symptoms related to post-concussive syndrome. So seeing patients across the spectrum, including in the hospital to outpatient and inpatient rehabilitation, and being able to deal with patients who had multiple symptoms, multiple comorbidities, and treat them holistically. So hopefully you'll see it from that kind of approach as well. So first we'll go over what are the basic terminologies. There is not an official 100% definition of what long COVID is and how it's defined across agencies, but different agencies have different definitions. General, we're talking about a syndrome that's characterized by persistent symptoms actually and health effects after having COVID-19 that's caused by SARS-CoV-2 or presumed having COVID-19, because at some point in the pandemic some patients were unable to get testing, and then it's going to be lasting for weeks, months, or longer. Currently it's about a 4-week definition that is mostly accepted. Long hauler is the COVID-19 survivor who is dealing with these impacts. A lot of times I won't use that term. It's a patient-derived term, but I like to use patient-first language, so I'll usually say like person dealing with long COVID rather than calling them a long hauler. And then there is the post-acute sequela of SARS-CoV-2, or PASC, and this was a definition from the National Institutes of Health that they started in February of 2021. Post-COVID conditions is what's used often by the CDC, and there's data related to on their website with looking at post-COVID conditions. But again, a lot of times it's this. The World Health Organization also has a definition. I think they have a great definition because it says, you can get COVID, you can get over COVID, and then have symptoms that emerge, including new symptoms that emerge within 2 months or 3 months after having COVID. And so this is all kind of under PASC, or post-COVID conditions. Or I'll be mostly saying long COVID through this talk. And then there's a little nuance to this diagnosis when it comes to PASC. So this is not, again, official, but a good way to think about it. So when someone has post-acute sequela of SARS-CoV-2, there's definitely patients that have persistent symptoms, and there's an obvious cause. And that's going to be ones where they've had tests and you see the abnormality. They have interstitial lung disease, they have myocarditis or heart failure or pericarditis. They might have acute kidney injury. And then there is also a group of people where it presents as part of the syndrome that's long COVID, and that's the syndrome where they have the debilitating fatigue, post-exertional malaise. They present maybe like myalgic encephalomyelitis, which was previously known as chronic fatigue syndrome, or I'll be calling ME/CFS. They could have post-viral autonomic dysfunction as well. And so always PASC does not have to be long COVID. So what is the pathogenesis? What's going on? And this is still being researched, still trying to figure out what exactly is happening in the body. Probably these are some of the 4 leading theories on what's going on in patients that have long COVID. So first, immune dysregulation. And the immune dysregulation may actually be driven by there's viral antigen persistence. And so that means there are pieces of the virus that are still found in the body and that are driving the immune response to continue to, the B cells to make antibodies, or driving T cells, and T cells are becoming exhausted. And a patient can feel very bad if their immune system's always on the go, go, go. And they've found different studies where there's been biopsies in the GI tract and they've found pieces of the antigen. They've had studies where including women who had been pregnant and they had gotten COVID during pregnancy, and afterwards their child was born and the baby in the stool had pieces of the antigen in their stool. So that is kind of pointed to, yes, there's viral antigen persistence that may be occurring in these patients. And there could be reactivation. There, again, the immune system becomes dysregulated. The next one is gut dysbiosis, or that means that we know that there's so much more with gut-brain connection. We know that our microbiome and our GI tracts are so important, and that often drives some disease states. That even in stroke, we know that after stroke, patients have gut dysbiosis. So that is another part of what is possibly or likely happening in long COVID. And there's been some studies in ME/CFS saying that the gut bacteria and the gut flora is different in those patients versus patients who don't have it. So probably another factor that's going on for sure. There is autoimmunity and immune priming. So with this dysregulation of your immune system, in some cases it's driving autoimmune disease, whether that be driven by the immune system becoming dysfunctional, molecular mimicry, just the stress of the infection causing autoimmunity. Then those are all reasons also that patients are having long COVID. There is blood clotting and endothelial abnormalities. Actually, at first everyone thought this is a respiratory disease, but it's definitely more than a respiratory disease. It's vascular. There's endothelial dysfunction. There have been found in multiple patients to have microclots, hyperactivated platelets, and so this is what's going on in the endothelial and vascular system. And so are these microclots being, caught up in kind of small capillaries, and they're not being good blood oxygen perfusion to tissues, and that's why patients are becoming fatigued or can't exercise like they used to. And then we know there's also large clots related to COVID-19 as well. There was an increase in thrombotic strokes and clots, DVTs, and pulmonary embolisms with COVID-19 as well. So not just large clots, but also microclots. And then another thing is dysfunctional neurologic signaling, and with that, that is where some of the autonomic dysfunctions occurring with vagal nerve issues too. So those are the the pathogenesis that we are still trying to figure out right now, but kind of the leading theories, and it may be more than one of the above. So who gets long COVID? What's going to make you at risk for getting long COVID? And there's been several studies, and there is a lot of things to figure out with this. And some of it is with these different studies, or what's going to predict long COVID. And it's been anywhere from Cell to Scientific Reports to Nature. And there's some disease states, diabetes, history of asthma, history of being obese, history of having connective tissue disorders, having urticaria, having even ADHD, having specific antibodies, having a history of having Epstein-Barr virus, and the Epstein-Barr virus can be reactivated, and if you have that reactivation, it can drive long COVID. There's another study where they found higher viral loads, so viral loads of of SARS-CoV-2 viremia, those patients having higher risk of long COVID. And then also certain immunoglobulins. There's also certain cytokines that are elevated in these patients that end up getting long COVID, including certain interferons and certain interleukins that usually are not elevated, and that may put someone at risk of having long COVID. Again, we don't have the perfect biomarker yet to say who gets it at the beginning. We don't have the perfect blood tests yet. More work needs to be done regarding that. But again, it is it ends up, when we look a little bit more at the epidemiology, that it could be a lot of different people who are at risk of getting this. So what does recovery look like? So for patients, we knew at the beginning of the pandemic, COVID had a lot of severe cases. We didn't have the antivirals, we didn't have all the treatments. Patients were getting very sick and in the ICU and getting ARDS, and they were getting the COVID lungs. And there's a picture, an example of that right on the slide. We are not seeing as many people get that sick now, though they still are. So what can we expect from recovery? So that's what I will talk about next. First is, what are the different outcomes for these patients? And I think COVID can be anything from asymptomatic, wonderful, great for those people, mild disease, which usually means, you can kind of have symptoms and you're dealing with it at home. Those who have moderate disease usually have a pneumonia and get pneumonia related to it, sometimes hospitalized. Severe disease, again, those patients are definitely hospitalized. And then there's like extremely severe, where they're hospitalized, intubated in the hospital for a long time, almost at risk of dying, multiple organ failures. And with those, there are studies on who gets long COVID. And definitely patients who were hospitalized had a higher risk of having symptoms that were happening at 6 months and at a year. And there's been studies that showed that. First they came out of Wuhan, then there's studies from here in all parts of the globe. But even the risk factor of when you have very mild COVID, you can still get long COVID. And the studies showing anywhere from 10% of those people to 20% of those people. Will touch on that. And some people get COVID and they recover completely and they don't have any ongoing symptoms, and that's wonderful. Some, like I said, get COVID, might feel better, and then get these new reemergence of symptoms or new neurologic symptoms, and that's part of their long COVID. Some people have just continuation of symptoms since COVID, and their just symptoms don't get better. And then there's also, we don't know what's going to happen down the road. This is one example of this, I like to say, is polio. So when patients got polio, some of them got better, and then actually 4 decades later, some of them got what we know as post-polio, where they had kind of a reemergence, new weakness, needing new braces, new assist devices, new breathing tubes, and that wasn't for decades. So we still don't know what's going to happen decades down the road after having COVID-19. We have also seen studies with, there has been increased risk of hospitalization for a year after having COVID. There's even, after multiple infections, increased risk of death. A lot of those studies come out of the VA system, and it's going to be, again, focused more on the population that is in the VA, which is often a male population more than female, and an older white male population. But it does show risk factors of more hospitalizations, more illnesses, more diagnosis, and unfortunately death too. So what are the statistics on the numbers? And when the data comes out of the CDC, they started doing the household pulse survey at the beginning of the pandemic, and then about 6 or so months ago, they started asking questions related to long COVID. And when those surveys came back, they found about 19%, or 1 in 5 people who had had COVID, were dealing with ongoing symptoms and have long COVID. And they were saying, okay, if it's 40% of people in the US have had COVID, and it's 1 in 5, then it's actually going to be 7.5% of the population, or 1 in 13 people that are adults in the US that are dealing with long COVID. So very significant numbers, especially if you think that there's been over 100 million people who've had COVID-19 at this point. Other things they found, it was older adults, but not the oldest adults. So kind of that 40s, 50-year-olds, definitely women more than men were having long COVID. And some people, that's pretty interesting, because a lot of the ones that were hospitalized and got very ill and had severe disease with the initial COVID are going to be older persons, 80s, 90s, and men more than women to have severe disease. But it's very interesting to see that long COVID happens more in women, and women in their 40s. And so does that go with the hypothesis of the autoimmunity? Because that's also, women who have autoimmune disease are autoimmune disease often happens in that same 40s to 50s, and in women more than men, so may lead to some of that pathophysiology happening. And then as far as race, Hispanic was the highest ethnicity that had long COVID, with about 9% of Hispanic adults having long COVID. And then if you continue to look up National Center for Health statistics, so what's happening, continuously more recent, and this is some of the data from the end of 2021. So it's still, high percentages depending on the age. Again, the highest age being in that 40-year-old, and it's kind of a bell curve. So like 30s, 40s, 50s, up to 18% or more. Females being higher than males, the Hispanic ethnicity being the highest with other races and ethnicities. The other thing is those who had previously had a disability also were more impacted by long COVID too. And then you think, okay, well, what about these new variants? These new variants are mild. Some people are having very mild symptoms, like the BA.5 variant. Then there was a preprint even related to the BA.5 variant saying 21% of patients were still having symptoms at 4 weeks. So again, it doesn't matter the severity of the illness, there's still a risk of long COVID. There's some data there that was just saying even patients who are boosted, fully vaccinated, were even at risk too. So yes, there is some protection. You're not going to get a severe disease from vaccination, but even those who are vaccinated can get long COVID too. And what happens to children? So children are another important population that we have to look at and consider too. A lot of my practice is more adults, but there is data out there for children. And they did show that children and adolescents, there was risk of events happening after COVID too. So they do have long COVID. The percentages are a lot smaller. It's definitely not as high as it is for adults, but they can also have long COVID. And some of the more likely events that were happening were pulmonary embolism, myocarditis, cardiomyopathy, thromboembolic events, type 2 and type 1 diabetes too, asthma type of thing. So this is the more likely were happening in children, and there was increased risk of that. And the other thing we have to say, there are still, kids can get COVID. There are still, several thousand children who unfortunately died from COVID. It's still important that children get vaccinated and try to be as safe as possible, because even though the risk is small, there are these risks of events. So what are some of the complications? And at the beginning of the pandemic, when there was a lot more severe disease, I wrote up some papers with colleagues from 11 other countries, and we said, we've seen patients be very sick, have ARDS, and be in the hospital, and also have MERS and SARS, which of course weren't as large pandemics, but also were outbreaks too. And what were we seeing in those patients, and what can we expect to see in regards to complications? And definitely these were things that we saw and continue to see for patients, especially ones who are hospitalized, having respiratory impairments, needing oxygen for a prolonged period of time, having cognitive sequelae and having cognitive changes, cognitive deficits, having nerve changes and muscle changes, critical illness myopathies and critical illness polyneuropathies, problems with swallowing, joint pains, and psychiatric problems, mental health conditions too. And we talk about this and how it's important to have rehabilitation medicine specialists and therapy specialists involved in patient care from the time that they're in the hospital. And this is something that we do recommend early mobilization, getting patients moving even when they're in the ICU. And so definitely this was hard when patients were very severe, and now that patients we know kind of the timeline of when they're not going to be as infectious. We have PPE now, then it's important to get patients moving as soon as we can get them moving. And this is critical care 101, early mobility protocols, and doing those early mobility protocols in the ICU. And it will help decrease muscle wasting, because we know the patients, the more organs they have failed, the more weakness that they have with their outcomes, and the poorer the outcomes are. So this study in the Journal of Hospital Medicine, it was big data from University of Colorado system, and they have multiple hospitals, and they had multiple patients who were hospitalized for acute COVID-19 in their hospital systems. And they wanted to look at which of these patients who are hospitalized in their hospital system received therapy services while they were in the hospital. So physical and occupational therapy, who is more likely and less likely to get these services. And, there was a good percentage who were able to get these services, which is wonderful. But when they looked at like what patient population was least likely to get these services, that in their study it was patients again with Hispanic ethnicity, so and ones who spoke Spanish as well. We know already there is healthcare disparities, so it's important maybe that there are certain types of policies in place where patients who are sick or have a certain condition, that there be an order for them to get therapy, so we're not forgetting certain populations who are often minoritized and also don't get the same health care that others do. And inpatient rehab. So if you have a patient that is critically ill, sick, has had COVID, has been in the hospital for some period of time, will they benefit from getting more intensive rehab afterwards? And now we have more and more studies that say that the answer is yes. So again, if you're in a hospital system, if you're a hospitalist, you have these patients that are hospitalized with critical illness, does it benefit them to go to inpatient rehab? Yes, they have multiple sequelae, they have disabilities, and an intense interdisciplinary rehab program is helpful. There have now been prospective studies that say what happens to these patients when they go to rehab because of their respiratory issues, their balance, their gait abnormalities, their inability to do activities of daily living. And it's crucial for them to get into rehab and participate, and they will do well with it. And then just some other studies, post-ICU, getting into inpatient rehab. This one's for England, and they compared them to what about patients who didn't have COVID-19, and the ones with COVID or didn't have COVID, they all benefited just as well. So it doesn't matter if you think they're not going to do as well in rehab. That's not true. They do just as well as other patients who go into inpatient rehab, and they benefit from it. And then this was a study that came out of Korea, again, comprehensive rehab for patients who'd had COVID-19, and actually they showed that the more that they got, the better that they did. And so again, getting patients in patient rehab. And another slide that I didn't get to add in that was a more recent study, they looked at all the Vizient data for patients who had acute COVID stays, and then they looked and they compared ones who had gone to skilled nursing facility versus inpatient rehab. The patients who went to inpatient rehab had been more critically ill, had had longer length of stays, and then when they looked at who had discharged back to acute care more, it was often those who had gone to skilled nursing facilities. There was almost like twice as risk of coming back to acute care than those who went to inpatient rehab, though the ones who went to inpatient rehab were sicker to start with. So it's a good place with multidisciplinary care for your patients. So what about patients who are not hospitalized, and that we're going to now transition to ones who have long COVID symptoms, and there started to be a lot of patient-led data. So this study came out of the University of Indiana. It was one of the first ones where they said, let's go into where these patients are congregating, online forums, and in social media groups, and start doing a survey and asking what symptoms they had. So this was 1,500 patients earlier in the pandemic, and they said, what are the symptoms that you have? And then they gave a percentage of these, and you can see there was multiple symptoms, almost 200 in this study. And these patients, the number one thing was fatigue. After that, muscle body aches, shortness of breath. They couldn't concentrate or focus, difficulty to exercise, headaches. So these are things that you'll start seeing over and over again as you see this patient population. Another thing is from that same study, when they looked at pain-related symptoms, that 26%, so 1 in 4, had some type of pain complaint as well. So this might be something that's going to come into your office, your outpatient office, or a pain practice, or a PM&R practice where patients are going to say, I have low back pain, I have upper back pain, I have joint pains, and that could be related to the inflammation and the autoimmunity and the dysregulation of the immune system that's driving these pain complaints. Because we know that, like I said, there's abnormal cytokines that occur after COVID-19, and some of those abnormal cytokines are similar to ones that they see in patients who have chronic pain or in patients who have failed back syndrome. So again, that inflammation is not good for patients and for their pain, and they'll have multiple pain-related issues. So what does big data say? And this is where they look at electronic medical records and try to say, like, okay, well, we have these patients who took COVID PCR tests, and some of them came back positive and some of them came back negative. And if it came back positive, they can look and see, like, what was their utilization of healthcare? Did they get more diagnoses? Did they have more issues after being positive? And so in this one, from 40 systems, electronic health data, this was over 1.7 million people that they looked at. They looked at ones who were 20 and over and one who were 20 and younger, and yes, it was about 11% prevalence of new diagnosis and issues and new symptoms. So again, fatigue, sleep disorders, again, things that were worse if they were hospitalized, even in younger than 20 years old. Again, like I was saying, adolescents, kids, it can impact these younger adults for sure. They had change in bowel habits and fatigue, and had new diagnoses around anxiety and depression. And so I think in the study they had said it's just about 11% prevalence of PASC, and I went out and was tweeting about this and said 11% is a lot. Again, we're talking about 100 million people, and 11% could be 11 million people that are dealing with these ongoing or new symptoms that they never had before. And so it is a very high number. So what about these new symptoms? So that's kind of one of the really interesting pieces of PASC. And this was a study out of Paris, France, where you think everyone's living their best life there, but this was their long COVID clinic, and they had mostly female patients in their 40s who had not at all severe COVID, and mostly were not hospitalized patients. And they found, they looked, what were your symptoms in the acute phase, and then what were the symptoms in this prolonged phase. And they found in those patient populations that 25% were having new neurologic symptoms that they did not have when they initially had COVID. And they also had late symptoms in seven different categories, respiratory, musculoskeletal, GI, again, the neurologic system as well. And the other thing is about half of them had a symptom-free interval. So that means they got COVID, they got over COVID, and then a time about, I think in this case it was 25 days later, this is when these new symptoms or the symptoms came on, these late symptoms. So again, is it something with the immune system? Is it something with the inflammatory cytokines changing? Is it the dysbiosis, and now that's happening in the abnormal neurologic signaling? So more that we have to figure out. But again, it's a timeline type of thing occurring. This is a systematic review and meta-analysis of multiple studies saying 47, almost 48,000 patients. They looked at from all these studies, what were the most common symptoms. And so 5 most common were fatigue, again, and this is very debilitating fatigue. We'll go about it in a little bit more. Headaches, attention disorders, hair loss, and dyspnea. So those, again, big symptoms that patients have. And yes, a lot of people like to think about it as symptoms, and symptoms are sometimes really hard to, categorize. Or the thing is with these patients, they may say, I feel really fatigued, but you can get an EKG, you can check their echocardiogram, their lungs, their chest x-ray may look good, and there may not be a very obvious reason for the fatigue. But we have to start really thinking of this as, yes, organs are being impacted. Again, if this is vascular endotheliitis, immune-mediated with dysbiosis, then we can't just think of it as, oh, these are symptoms, but that multiple organs can be affected. So the symptoms might be chest pain and palpitations, but we know that there can be cardiac impairment, there can be myocardial infarctions, there can be POTS, or postural orthostatic syndrome or autonomic dysfunction. Neurologic issues could be related to microclots. It could be related to dysautonomia, to ME/CFS. So again, we know these things are happening: immune issues, vascular issues, dysautonomia. And so considering these symptoms in the context of what's going on at a pathophysiologic level. This patient-led research collaborative has been excellent about leading research from patients who themselves have been dealing with long COVID, but were in science or research fields before, and they really want to forward the science, so that's been wonderful. In this study that was in eClinical Medicine, again, it was related to international web-based survey of patients with long COVID, again, same age groups, 40, 50-year-old women, less than 10% being hospitalized, and they had 200 plus symptoms, and 96% of these patients were still having symptoms at more than 90 days. One of the things they found was, the more symptoms that a patient had, if they had 15 or more, then that was also going to be one of the signs that they were going to have issues for more than 90 days. The other thing is that there was a lot of relapsing remitting, so there was at times patients were having exacerbations, and the exacerbations could also be from stress and from exercise too. In this compare long COVID cohort, this was 968 patients that they looked at 2 months, and then they followed them for a year out, and they found out these patients who were having symptoms at 2 months, that there was still 85% that were having some ongoing symptoms at a year. So unfortunately, still very prevalent and still having impact. And they also looked at the same thing, relapsing remitting, so symptoms would come and go at certain times. And then they looked at the prevalence, like which symptoms got better, which ones stayed the same, and which ones got worse. And the 8 ones that got worse are listed here on the slide, but kind of the number one thing was neck pain, back pain, low back pain. So this is something that patients may have. Is it due to, the inflammation, their mobility, a combination of everything? Paresthesia, so still some of those like numbness, tingling complaints can definitely get worse. Bone and joint pain, hair loss, blurry vision. So a lot of things that unfortunately were getting worse during this time frame. This is a very nice slide because I like to say there's so many symptoms that seem so disparate, and you're like, what's going on? I've talked about there's multiple mechanisms. We don't have a perfect blood test for this at all. We don't have an easy way to check for microclots on patients. And what are these? There's probably likely those multiple pathophysiologies that are driving all these symptoms. And so they can be interrelated, even when you have normal tests, our traditional normal tests, because we don't have all these other ones out of research yet that have been abnormal or an easy way to check for them. And so pain, fatigue can be related to disrupted immunity, inflammation, and nervous system dysfunction. And I think we have to see this and say, maybe there's not huge organ damage that we're seeing, but this still needs a holistic way of treating these patients, of trying to decrease inflammation, of trying to control these symptoms, and doing it in a patient-centered approach. And this is another very nice picture that came out of an article from Brain that says, long COVID, and these are some of the 4 categories that a patient may fall into, sometimes more than one, sometimes, almost all of them, but exercise intolerance, we'll see that. Cognitive mood disorders, autonomic dysfunction and dysautonomia, and pain syndromes. So that gets me to, how do you diagnose this? How do you diagnose long COVID? Like I said, both the CDC and the World Health Organization say this is not, there's not a biomarker. This is a clinical diagnosis. So you can make this diagnosis and say, okay, this patient told me they had an infection, known or likely known COVID, and we listened to the timeline of events. Did they have symptoms? Did they continue? Did they have symptoms they go away, and then they had reemerging symptoms within 3 months that are very much aligned to how patients are presenting with COVID. You do not need abnormal lab tests to rule it out. A lot of tests can be normal, and it is not a diagnosis of exclusion. So patients like to be validated. Some of them are very well educated on this, and we have to be not afraid to say, yes, this is long COVID, now let's deal with this from a holistic approach. The other thing I recommend is using validated measures when you're talking to your patients about their symptoms and looking into their symptomatology. So there's, neuro quality of life scale, health-related quality of life. The Compass 31 is great for patients who have dysautonomia or autonomic dysfunction because it looks at it in very different body systems. DePaul Symptom Questionnaire, there's also a short form for this. These are for patients who may have a chronic fatigue ME/CFS type picture, and it's able to capture that in a validated measure. I use fatigue severity scale. The fatigue severity scale is very easy to give. It's something that's been validated in a lot of other conditions. So sometimes I can say, well, this patient had a score of 63, which is very high on the severe fatigue severity scale. That would be equal to someone who had multiple sclerosis severe fatigue, and then that's something that's understandable to people. And using the symptom measurements that are validated really can make a difference between a patient getting disability coverage or being denied, because you're at least putting it on a way that someone can understand and that has been comparable to other disease states. In this study, they looked at immune profiling, and it came out of Yale and Sinai, and they had patients that they recruited, patients who had never had COVID, ones who had COVID and recovered, and ones who had had COVID and have long COVID. Believe it or not, the hardest one that they could recruit were ones who had had COVID and completely recovered, because even some patients were like, I had COVID, but I'm not like 100% on all my workouts yet. Well, then that was maybe not completely recovered. And they looked at, cross-sectionally at some of the hormones, immune, a lot of data, as much as that they could get on them. And for one thing, that structural pathology was not correlating with long COVID symptoms. So again, only a small percentage of patients may have had true like myocarditis or, issues with their lungs. And a lot of times, for the most part, those were fine. But what they found in the immune system was different. And so two major findings. One was a lot of them had low cortisol. So it's something that can be tested in your patients. And a lot of times, even when I find low cortisol, I'll do a stim test, and that might be normal, saying, okay, so their adrenal glands will be normal, but is it something that's happening higher in that HPA axis? The other thing that some patients had, and it wasn't all of them, it was only a certain percent, was exhausted T cells. So about 20 to 30% of these patients had very high levels of exhausted T cells, specifically CD14, CD16 monocytes. And so that is, again, showing the immune system activation and being dysregulated, but it wasn't in all the patients. So again, those are some things that were very interesting in these findings. So we have to figure out, what patients that have long COVID, what is driving the symptoms in different patients, and then figure out which treatments are going to be best. So if someone has viral antigen persistence, will giving them the antiviral Paxlovid help with their symptoms? Now, this is one of the main trials that's going to be through NIH Recover, as well as Stanford's doing the study as well. If there's this viral antigen persistence, then will being on Paxlovid help? Is there something that we need to, help with patients' immune systems like we do in patients who have HIV? Do we have to give steroids for the cortisol? These are all things that still need to be studied further. So things that I've learned about long COVID, everyone has, like I said, there's 200 symptoms. So people may have different symptoms, different courses. They want to be heard, they want to be validated, and they want to know maybe there's some options for symptom management. As far as we know that COVID-19 disproportionately impacted certain populations, especially certain minoritized communities of color, Black, Latinx, other Native American populations. And we also know from a rehab medicine perspective that sometimes these are the same populations who don't have the same access to healthcare, don't get the same rehabilitation care. So I wrote with some colleagues about a call to action to make sure that we were creating rehab services and giving this rehab to people who are survivors from these marginalized communities. I come from San Antonio, which is a large majority minority city of Hispanic. And so I said, this is something we have to address. We have to be able to make sure patients are going to get appropriate care after having COVID-19. So I opened South Texas' first COVID recovery clinic in around July 2020 and started serving patients. We tried to serve them holistically and make sure that they get access to care and provide them with our services with a multidisciplinary team approach. What have we seen? Anything from my cough's not getting better, I still have congestion, to patients who've had multiple strokes, patients who had anoxic brain injuries from a cardiac arrest, patients who've had 4 limb amputations. So it's definitely, this very large continuum. And not just patients who are hospitalized. Most patients I see have not been hospitalized. They are people who are trying to work, their parents, they're your friends and colleagues. Yes, even my colleagues I've seen in this clinic as well. So just a little bit about some of the data that we saw in our initial months. So again, mostly women, 65% were women compared to 35% males in the clinic. A lot of them, 25% had been hospitalized. Actually, probably up to this point, this is only the first maybe year of the clinic. Now we have even less patients who are hospitalized, and most had mild disease. Demographics, again, the highest age group there, ones that we saw, were 40-year-olds, and the Hispanic ethnicity was about 60% of patients, which makes me happy because that kind of mirrors what we have here in this town. So some more data when we looked a little bit more into it, date of infection, and so we wanted to say, when they got these people in these clinics that are diagnosed now with long COVID, and does date of infection match when there was COVID waves? And so we kind of put it and compared it to, in the red was the CDC data, in the green was Metro Health, which is San Antonio area, and the red was in our clinic. So you can see it very much matches, the surges that happened. But there's probably a little bit of increase during that first initial surge, that initial wave of seeing patients who had that initial wild type variant getting a lot more long COVID. We also looked at other long COVID predictors. So we had a symptom scale based on the symptoms that the patients had. And, it was either high symptom load or low symptom burden. And we saw having female sex, usually they had moderately higher long haul symptom score. So again, a lot more burdensome on women. We looked at some of the mood data as well that we had collected. So again, if they had a higher score, they were often also having more anxiety as well as post-traumatic stress disorder. So again, these patients, they kind of were traumatized from having COVID, and then for these patients, they're re-traumatized because they're going through the system, and a lot of times they're not validated. People are telling them, oh, you're fine, your tests were fine, nothing's wrong with you. So it's important for us to think about that and say, validate patients, tell them, we're still learning more, there's still tests that we don't have access to for you, and let's, hope that we can get a treatment and try things for these patients as much as possible and not re-traumatize them. And it is not, something that they're making up. It's not in their head. It's not somatization. There is study after study showing issues with, viral antigen persistence, immune system, endothelial dysfunction, microclots. And just because we don't have a way to test it in each one of these patients does not mean that they're making it up. So what is happening in the cardiovascular system as far as the cardiovascular system, these patients, they may have chest pains, and sometimes it's not cardiac chest pains, and sometimes it's cardiac chest pains. So if they have these exertional symptoms, please work them up. It's very important that you do so. Palpitations is a huge thing, and so that may be related to, increased PVCs. They may have POTS or autonomic dysfunction. They can get breathlessness and syncope and pass out. And it can be anything from, again, I've seen myopericarditis, myocardial infarctions, clots, autonomic dysfunction, and vasculitis. So these are things that need to be worked up traditionally. The other thing is return to play. So when can someone that is an athlete, someone that wants to get into activity, when can they start getting back to that activity? And it's very, this has come out now, JAMA Cardiology journals, different British Medical Journal of Sports Medicine, AMSSM has now have data on how can someone who wants to get back to activity get back to activity. And it is very much like a concussion type of protocol where it's like this graduated return to activity. So definitely while you're acutely ill, please don't be pushing yourself and try to do exercise at all. Once you're better, then it's one of those very, slow return to play. And it also depends on the symptoms that you're having. If you had mild disease, then it can be a gradual return after, you've completely recovered. If you had more moderate or severe disease, and it is recommended that you have a workup for that, and a cardiologic workup before getting back to that same activity. If you have risk factors or an older person, I also recommend that you get, screening EKG and troponins, and this is what the data shows. If someone has myocarditis, they actually have to not do exercise for 3 to 6 months because of the risks that come with that too. So what happens with athletes and long COVID? And so this study is based on NCAA registry. So you think like NCAA athletes, healthiest people, like 20-year-olds, top of form, otherwise really healthy and young. And they looked at what happened to these athletes when they got COVID. And even these athletes in this registry, 1.2% were having persistent symptoms and 4% were having exertional symptoms. So that means when they were doing exercise, they had symptoms that came on. And so again, that warrants a workup. And these athletes were able to get things like cardiac MRIs. And even once they had cardiac MRIs, 5 out of 24 who are having chest pain with exercise had abnormal cardiac MRIs. So again, sometimes patients may need this. And then there was other issues with ones who had symptoms. Some were having inappropriate sinus tachycardia, POTS. They had pleural effusions, pneumonias. So again, worth working up. And even though it was a small percentile of these patients, it was still the healthiest ones who you would expect to be completely fine. And then you continue to see things in the news all the time about athletes who can't get back to play, athletes who have to quit what they're doing or can't work out like they used to. And even Messi at one point was dealing with long COVID symptoms. This was before, obviously he got over it and won the World Cup, which is great for him, but he was having struggles after COVID-19 and saying, almost felt like he went back soon, because again, one of those things is like you can make things worse by pushing yourself too hard. And The Economist looked at like even elite footballers, because in Europe, this was in Germany and Italy, they were doing really close testing on athletes, and so they could follow and see like when did they have it and how they do afterwards, and it even impacted how many passes they did, how many minutes they played, 4 months, even inclusive up to 150 days, still having issues with that. Another big thing I'll hear is, okay, for some people who are athletes and they know how much physical activity they could do before, they may say like, okay, I've been told I don't have cardiopulmonary disease. My x-rays, my scans, my EKGs, they all look normal, but why do I feel like I can't exercise like I used to? And one good test that's been that's been done is cardiopulmonary exercise testing. And in this specific study, they looked at not just centrally, but peripherally, and what was happening peripherally with this testing. And here, patients, they didn't have cardiopulmonary disease, but they still had a marked reduction in their peak oxygen consumption, but it was peripherally and it wasn't centrally. So it's like their heart was working, but something's happening where the blood is not getting to the muscles in the right way and being there. So again, vascular disease, microclots, this might be part of what's happening. And then they were having exaggerated hyperventilatory responses during exercise. Another study, again, looking at this, there's, patients who had all normal tests. 45-year-old was the average age, 41 patients who had normal tests. And once they did cardiopulmonary exercise testing on these patients, only 2 of all of those had completely normal tests, and otherwise they were abnormal. They again had decreased oxygen consumption. They had ventilatory abnormalities. They had hypocapnia, so end-tidal CO2 was low in many of these patients, and about 46% met the exercise criteria for ME/CFS. And so again, the initial regular screening tests we've done were fine, but again, only 2 of that 41 patients had normal tests once they got cardiopulmonary exercise testing. And this was in JAMA Network Open, and they looked at meta-analysis of all the studies that have now done on cardiopulmonary exercise testing. And there's a picture of me, just kind of, this is how some patients say, I feel like I ran a marathon every day, even when they're not running a marathon at all every day. But that's how bad their body, is fatigued and crashed. So this is like at the end of a marathon where I feel horrendous and terrible. But yes, it showed exercise capacity was decreased for 3 months or more in patients who are having long COVID. And it was like something like, one of these studies had said equivalent of 10 years of aging on your exercise capacity just from even having COVID, and not always even the most severe COVID. So it's really impactful when you talk about an athlete who is doing really well, and they lose kind of 10 years of their exercise ability. Enhanced external counterpulsation is a treatment that was used before for angina, and for patients who had angina that kind of were unable to get invasive treatments, and so they would use this treatment that's basically putting large cuffs on the legs and is putting a lot of pressure on your legs while the heart's in diastole. So you get a 3-lead EKG and you get these large cuffs, and there's a good amount of pressure that helps the blood flow. And so with that, there's diastolic augmentation, there's increase in nitrous oxide, there's decrease in inflammatory markers, there's increase in vascularity, and therefore increase in cardiac output. And so this is great for patients who have angina, but we've now been doing it in patients who have long COVID as well, and has been showing really good results. Again, this is not a randomized control trial, but multiple patients who have already gone through these treatments, including multiple of my own patients who are getting flow therapy or EECP and having improved fatigue markers, any angina, dyspnea, 6-minute walk test. So it's something, again, the healing the endothelium, helping the endothelial dysfunction, helping with vascularity and cardiac output, and helping the patients as well. There's a couple of publications on this. So what's happening in the neurologic nervous system? I think some of the data showing anywhere from, depending on what you read, 36%, 40, 50, 70% of patients have some type of neurologic symptoms. And it really, if you read things, can be anything and everything for COVID-19, from Guillain-Barré syndrome, myopathies, nerve issues, headaches, encephalopathy, encephalitis, seizures, again, anosmia and dysgeusia, vestibular nerve issues, things with, hearing loss, vision changes across the board. Your neurologic systems really impacted. And, there's studies like, okay, they've looked at cerebral spinal fluid, and even in cerebral spinal fluid for patients who had cognitive symptoms, they had abnormalities, including increased proteins, increased oligoclonal bands. That's things that you see in someone who has MS, and this is what we're seeing also in patients who have long COVID. And the controls, so the ones who didn't have long COVID, didn't have these findings in their CSF. We know that post-intensive care syndrome can have the cognitive sequela, but we're seeing it in patients with long COVID as well. So there's been studies where they did PET tests on patients, and they have hypometabolism in the brain. So again, just not the same metabolism going on in their brain. They're sometimes not getting enough blood flow to their brain. There's again, tying into the vascular system. There's a study where there was Alzheimer's-like signaling in some of these COVID brains. And so what do I do for some of those patients? Some of them will need neuropsych eval to see in detail where are the limiting, get this in-depth testing and see where is it processing, is it attention, is it memory, and find out exactly what's going on. I'll send them for speech therapy to work on what is the issue, use memory techniques on them, and I will try medications that we traditionally use in patients who have brain injuries or even dementias, because that will help kind of enhance some of the dopaminergic receptors, etc. So this study was a UK brain bank, and so Biobank, they do scans of patients and just follow them over time. So they already had scans of patients before they ever had COVID. Then they had patients who got COVID, and then they rescanned their heads at some point after they've had COVID, and they looked at and compared the scans before and after. So they did notice some abnormalities in gray matter thickness. They noticed in some areas there was tissue damage in the primary olfactory cortex, so again, part of the smell. The other area of tissue damage was the left hippocampal gyrus, so that's tied into your memory. And then there was a reduction in the global brain size, anywhere from 0.2 to 2% of the brain even shrunk in these patients. And again, equivalent of 10 years of aging from having COVID. This was a big data study from the VA, and they had compared 150,000 patients in their system who had COVID compared to controls both before and after of patients who did not have COVID, like 11 million patients. And they said followed who developed neurologic sequela, and about many patients did, and there was a 42% increase in developing a neurologic condition a year after, in some point in a year after having COVID. So again, very high risk of these things. A study, just to tie back into a VA study where they looked at what happened when they gave patients who were in the VA Paxlovid versus ones who didn't, and actually ones who had Paxlovid were less likely to get long COVID. So again, something that I consider that might help decrease the viral load, might help decrease the severity. So something to consider for your patients. And this was also even if the patients weren't hospitalized. Headaches, a very major thing that COVID patients have, very common presentation. And sometimes it's like someone might have a little bit of headaches and they got really worse. Someone might have a migraine like once a month, and then they just get a migraine that can't be stopped. And the severity can be very severe for patients. Men often get some headaches in some of these studies, and a lot of times some of them are even analgesic resistant, like it's hard for them to take the headache away. And so we want to exclude secondary etiologies, make sure that some of these patients, especially if there's a neurologic finding or a very suspicious headache, then you may have to do an MRI and get imaging. I've had a patient even have a venous sinus thrombosis related to headaches. And then once you've kind of ruled that, then it's just symptomatic management based on the type of headache that they have. In this study, they looked at multi-system involvement in after COVID-19, and showed that a lot of what's happening is very similar to what happens in POTS, or patients who have dysautonomia. There's cerebral blood flow dysregulation, so again, not as much blood flow to the brain. Hypocapnic hyperventilation, so can you check in tidal CO2, because that's often impacted. They get small fiber neuropathy, so again, some of those paresthesias, you may get an EMG and the EMG is normal. EMGs only look at large fibers, so some of these patients, they need skin biopsies to see if they have small fiber neuropathy and be treated for their small fiber neuropathy. And then there's pain and abnormal inflammatory markers. Autonomic impairment's a big thing. It's neurocardiogenic. The postural orthostatic tachycardic syndrome, or POTS, is something that I've seen a lot of autonomic dysfunction. It can sometimes be blood pressure up and down. Specifically for POTS, these patients, they'll come in, they'll have dizziness when they're up. Again, they're not getting good blood to their brain. It's almost like a preload failure for these patients, and their heart rate will go up out of nowhere, and especially when they're up. And so it's a lot of their tests can be normal if you're just doing traditional EKGs and echoes, but really what could help diagnose is a 10-minute stand test. So you can look up, how do I do a 10-minute stand test or a 10-minute NASA lean test? And within 10 minutes, these patients will have symptoms, and their heart rate will usually go up by 10 beats per minute while they're standing, and often over 120. And they'll have these symptoms of orthostatic intolerance. And so for these patients, yes, you can manage them with fluids, electrolytes, compression stockings, abdominal binders, but really don't be afraid to do pharmacologic management. And I'll talk about some consensus guideline papers that will help you manage this. But sometimes a little beta blocker, a little midodrine or something will go a really long way for these patients. As well as the intense fluids and other pharmacologic things you can do, as well as an autonomic reconditioning program that therapy can do too. So again, dysautonomia, it's not just the heart rate, but like I said, you're not getting good blood flow to anything that's above the heart level, and so they're gonna have fatigue, brain fog, pain, headaches. This coat hanger pain is very common. They're going to have dry mouth. It's your whole autonomic nervous system. So they may have abnormal sweating, color changes on their skin, modeling of their skin, temperature sensitivity, and those kinds of things can be seen for sure. There's some very small studies about would a stellate ganglion block help. More needs to be said. The same thing with vagus nerve stimulation. More research needs to come out of this. In this study from the Lancet Psychiatry, they looked at 2 years out for patients, and they looked at both neurologic, cognitive, and psychiatric conditions. And interesting, if there was mental health issues, those returned to normal over time. But what didn't turn back to normal was the cognitive and the neurologic impacts. Those were still impacting these people's lives at 2 years. So no, you cannot blame it on this is just depression. That can actually occur because of inflammation that's happening in the neurologic system. We know that blood-brain barrier can be breached. We know there can be like microglial activation, microthrombi, and also decrease in your normal good healthy neurotransmitters like your norepinephrine and your dopamine and your serotonin, and that can drive some of the mental health things. But those things seem to tend to get better. Post-viral fatigue is major. A lot of these patients, in some studies, if you really screen them for ME/CFS or myalgic encephalomyelitis, they meet the criteria. In some studies, up to 40% of the patients. And so yes, you still want to do cardiac and pulmonary screens, but it's very debilitating fatigue. You want to check for viral reactivations. You want to check vitamin levels. There's an ME/CFS tiered testing recommendations. You want to make sure that they're sleeping, but a lot of time their sleep is non-restorative. There can be therapy, but you do not want to exercise these patients like traditional exercise because it will get worse. And they will get worse with traditional exercise because it's actually fatigues them more, believe it or not. So we have to learn about post-exertional malaise or post-exertional symptom exacerbation. And so this is a cardinal symptom of ME/CFS. And these patients, they can do regular an activity that they could previously do before, but it causes them to crash. And sometimes the crash is a day later or 2 days later, and they might just try to clean a room and they'll be in the bed for the rest of the week. And so you have to look and ask about these crashes because they have that. They can't do, traditional exercise like someone who's just debilitated because it is not debility. It's something with, again, dysbiosis, muscles, mitochondria. We're still learning even more about that. So learn about the proposed diagnosis for ME/CFS. The American Academy of Physical Medicine and Rehab has put together a collaborative of past clinics, and there's about 41 clinics, and we've come together and have created consensus guideline statements. So those consensus guideline statements are available, open access, for physicians to be able to assess and treat and work up patients who have long COVID. There's one, this is like a QR code, but one on fatigue, cardiac, respiratory, autonomic dysfunction, pediatrics, and cognitive, with more to come. A therapy program, there's a lot of information on longcovid.physio. So if you're in the therapy world, this will tell you how to do safe long COVID rehabilitation. Again, sometimes not pushing patients, especially if they have post-exertional symptom exacerbation. The World Health Organization has a living guideline on clinical management. There is even guidelines related to rehabilitation of these patients. Again, the point of it is to be multidisciplinary, be patient-centric. Don't force them to exercise if it's going to make them worse, and work together to get them back to regular everyday activities and possibly work if they can, but looking for that orthostatic intolerance and working them up if they have exertional symptoms. I know and teach triggers, so I want patients, physical and cognitive exertion can make them worse, stress, dehydration, we have to make sure these things do not happen. Alcohol consumption, sometimes that just makes people feel terrible with long COVID. And treatments, again, it's sometimes now till we have the magic pill, some of it's prevention. Vaccines is very helpful in some patients in feeling better, some it is not. There are, if patients have cognitive dysfunction, speech therapy, pacing for these patients is important, learning to pace and prioritize their activities. Some of these medications I talked about before. If patients have urticaria, mast cell dysfunction, then giving them non-sedating antihistamines can be very helpful for patients as well. Again, the autonomic dysfunction, the medications, and treating them both for their symptoms and with pharmacologically helps. Low-dose naltrexone has been used at ME/CFS. It's a really small dose, like 1.5 or 3 or 4.5, and it's been used also in fibromyalgia, in multiple sclerosis, and some other autoimmune conditions to help with, where it works at toll-like receptor 4 and mTOR, which is on the microglia, will help decrease inflammation and help the immune system as well. And so it has been shown also now in PASC to help with some of the symptoms. And so this is something that is also being trialed more, but I'm also not afraid to use it in my patients as well. Please support patients for disability and work accommodations. They do need this, and it is, things like, you can look at the slide, but limited hours, frequent breaks, seated, especially for patients who may have autonomic dysfunction. Do they need to decrease sensory inputs and be able to know that they're going to have flares, and maybe fill out those FMLA forms saying that they would need more frequent breaks or time off from work. It is considered a disability under the ADA, which means that works have to do, they have to provide accommodations, but because it's a disability doesn't mean that they are going to get disability, because this is a whole process that they have to go through. I also recommend getting patients in trials if they can get in clinical trials. So, in conclusion, thank you for being here. Use a team-based approach. Please screen for post-exertional malaise. Look at the patient holistically. Don't be afraid to give them a diagnosis and try things that are out of the box. These patients are really suffering. Also, a lot of them have a lot of education about this because they spend time looking it up. And so be open to, suggestions from your patients. Thank you very much.